Test 1 2 3. Test 3 2 1.
Test and stream, 1, 2, 3. Test and stream, 1, 2, 3.
David, can you hear me? Thank you. I'd like to call to order the virtual Board of Managers meeting at 1 p.m. Thursday, 8 April 2021. Is Leanne going to be doing the opening prayer?
I am here and ready.
There she is. It's yours.
All right. Thank you so much. So good to be with you all. Let us pray. Gracious God, on this day with bright blue sky and warm sunshine, we give thanks for a new day, for a new season that for so many feels like a season of hope. We pray that we can spring forward with courage, with resilience, with a unified vision for a future filled with promise. Additionally, we ask that you will help each one individually and all of us collectively to recognize the really good work that has been done in so many challenging circumstances. And so we thank one another and we thank you, and we pray this in your holy name. Amen.
Amen. Please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Any citizens? No. Next thing I have on the agenda, Roman numeral 4, is the approval of the minutes from the Board of Managers meeting on 11 March 2021.
This is Dorothy. Move approval.
This is Zim, second.
Discussion? All in favor, please say aye.
Aye. Aye.
Those opposed, say no. Motion passes. Board Chair report, which is the same report I've had for almost a year now, which is just thank you to everybody that we serve, the families of those that are doing the serving. Goodness gracious. You could start and you could be here for 2 weeks thanking everybody that's been involved. Next thing I have is CEO report.
Thank you, Dr. Weber. Just to give you guys an update that are virtually from us, we have Roger and Zim and Chuck here. And for those of you that are virtual, they discussed you a lot before. So even though you're virtual, you can't hear anything we're talking about y'all, because now we're just talking about y'all. But it is actually nice to have Chuck here. It is nice to have the ability to begin to be with each other. I really want to thank you all for what you did when we had the strategic planning. That was special in a lot of ways. One, it was special because I think that was an incredibly great strategic planning session. I want to thank our consultants, and I want to thank Lauren Poe, and I want to thank Karen and others that worked so hard for our strategic planning. It really was nice. And I think it's beginning to put us on really good footwork of where we go forward. But more importantly, it was truly nice to see you all. It was nice to be in the same room. It was nice to be with the board. I don't know how many CEOs talk about their boards in that manner, but I doubt many of them do, because it seems like boards are not something that they have high regard for. It's something they tolerate. And I think JPS is a different place. JPS is a place where I truly respect you and I appreciate you and I enjoy you as board members. I enjoy the dialogue. When there's a dialogue of disagreement, we do it with respect. That kind of follows rule number 3, the don't be a jerk rule. And that is you can disagree, but you can do it with respect. And I appreciate that. The fact that there was a lot of seeking joy in that meeting. There was a lot of people that we laughed a lot. We discussed some good ideas. So I want to thank everybody, certainly the staff that put so much hard work into that strategic plan. And as we go forward, I think we're going to have a really good strategic plan. The other thing that I would like to do is give you all an update. The officers and myself met. You know, Ron Skillins is now in the city that never changes in San Diego. And I'm guessing at this point, he's noticed two things. One, it's always sunshiny. And two, holy goodness, a house is very expensive. So I think there's probably been two revelations that have probably hit Ron. But I hope that he's fine and he's doing great. And we wish Ron the very, very best. And in that, we now have started our search for a new position for Ron's position. We have hired the Hearts Consulting Group. They did a very preliminary touch base with us. I believe that already had on the first day of applications about 10 applicants that had already expressed, and that's just cold. That's just putting out information that JPS is looking for this position. And for you board members, I think that speaks two things strongly. One, you're a strong board running a strong organization. And two, people want to join this organization. And I think that's powerful. So very, very pleased. We will keep that in line. Dorothy and I and Chuck, Karen and Roger discussed it would be a very similar search to what we've had in the past, and that you would have a search committee that would review those applicants, that would include the officers, and certainly going to be the discretion of the chair. But what was discussed amongst the officers was that the committee would consist of Karen and myself, Mr. Fisher, Mr. Weber, and Ms. DuBose. Roger's sitting to my right, and if there's if I heard something different in that, I think that's the approach that we were going to take, to keep it a meaningful group, that we could at least have 5 people that had proper input, and then recommendations would obviously come back to the board, but that committee would make a strong review of the candidates. So I feel good about that. I'm going to have a few other comments that I want to make, but what I wanted to do at this point, Jeff, if you could, we've got a incredible communications team. You all got to see a video that we ran during the strategic planning. If we can, this video, I think it speaks volumes to post-COVID as we see it now. It's not post-COVID, COVID's over. It's where we've been after a year of COVID. And I want to express to people, COVID's not over because an elected official says you don't have to wear masks everywhere. This is not the end of COVID. We have more COVID patients in today than we've had in a couple of days. We are not alarmed at all. It's not a number that we are concerned about. It's a number that has gone up by 4 or 5 folks. So COVID is not something that's disappeared. So David and or Jeff, if you guys would run this video, I think you all will appreciate this. If you'll listen to the words of the caregivers, it's pretty powerful.
It felt like we were driving in a car, but the windows were fogged. And nobody in the car knew where we should be going. But we knew that we needed to keep driving.
We had no choice. We had to do it. This is our job. This is what we know how to do best. As scary and as daunting as it seemed initially, we know this is something that we had to do.
And so standing in the middle of the COVID ICU, and you have patients that are refractory with their oxygen levels being super low, and you have to tell your teammates, I don't know what else to do. We've done everything that we possibly can do, and it's just, you just kind of feel like you can't help, and that's kind of like the most defeating feeling.
The patients would almost always ask me, and they would almost always say, I'm not going to survive, am I? And it was that realization that a lot of patients had. They were so sick that they may not come through this, and that was really heartbreaking and very difficult as, you know, being a physician, to kind of look someone in the eye and have that conversation.
We didn't know what the next week or month or year would look like. We didn't know what that would look like for us as healthcare providers. And in America. We didn't know what that would look like for our patients or for their families.
We have certainly learned a lot from the early days of this disease up until now. There's a whole lot of data. We certainly do have a better understanding.
We are seeing the evolution of the course. We're seeing patients get better and leave the hospital and stay out of the hospital, and seeing that is really what keeps us going.
There's always hope, whatever long or short. If the few patients that we have now, and this is the little break that we have, I'm recharged. I've had enough time, and like I said, the support system that I have with not only the people and colleagues that I work with, but my family and my friends, and the side hobbies that I do. I skate a lot, so that kind of helps with the energy.
There's always hope, and that's why we do what we do. We've seen the patients who have defied the odds and defied death, the miracles that have come through insurmountable odds. So there's always hope.
The reason I wanted y'all to see that video is to constantly put yourself and we as staff in a reminder of what kind of board you're on. Zim has told me on occasion, he said, I'm not sure why I got appointed to this board. I know why he got appointed to the board. It's because every element, every part of it, I need a preacher from a large African American community, and I need a board member that represents part of Northeast Tarrant County and then brings a whole lot more to the table. And I need a Zim Zimmerman and a Steve Simmons and a Steve Montgomery and a Trent Petty. And DT Nguyen, who's lived this life. When DT came to the United States, it was a public hospital that allowed him his health care. And for Dorothy DuBose, who put so many years into being a nurse, and the kind of man that helps people on the side of the road and has a scar from it for the rest of his life, and the kind of people that we have, and Charlie Powell, who can sit there and bring a banking interest but a heart to it, and then Amanda Arazola, who considers the fact of what it's like to give a voice to people that don't have a voice oftentimes. You need to see that video so that you understand to a large extent why you're on this board. And when somebody says there's always hope, we have, unfortunately, in the last couple of years, debated more about COVID's politics than we've debated the actual effects of COVID. And you saw in that video Jocelyn Z. And Jocelyn Z is a person that you can be around for about a minute and a half and pick up her energy. It's impossible not to pick up her energy. And yet she's had an inordinate amount of people die in her arms. And this has been something that's been so incredibly powerful that you as board members and we as staff can lose sight of a few things. I think I became the CEO here for a reason, and I think you all became board members here for a reason. And we have to deal with the particulars of where your scores are and how much money you have and how much money you don't have and where's the new building going to go. But I think those kind of videos are put together to make us realize who's going to go in those buildings and what kind of care we're going to give in those buildings. And when we lose sight of that and you just become a board member or you just become a staffer, you could serve on any board, or we could be staff anywhere. You could be staff at a widget factory and make widgets every day and go home and take your paycheck and put it to good use. But there's a whole lot more to this organization. And I think that video in about a minute and a half's time captures that. And it captures the life and the humanity at which we deal with every day. So if you all ever get tired of my speeches or my comments, I'm sorry, but I think you always need people in this organization that put greater things in perspective. We need to have a bottom line put in perspective, and we need to have retention and recruitment put in line. But we also have to remember, probably for the same reason Steve Simmons realized he got into medicine, there is a bigger force and a bigger factor here. And if we ever lose that, we probably shouldn't be board members and we shouldn't be staff here. So really proud of the team. And I think what you were able to see in that video is people communicating a heart behind a mask. And our 3 rules, that second rule of seek joy, we just upped the ante because now we have to smile behind a mask. And what we've discovered is you can really tell when people smile behind a mask and when they don't. So thanks, board members, for being on this board. And thanks for knowing that there is a true, powerful reason to be on this board. And there's a powerful reason that we as staff get up every day. And on some days we want to pull our hair out. But it doesn't really matter because there's really a powerful reason to be here. So, Mr. Chair, that is my report. So you can conclude with my report being very much like yours, and that's thanks. Thanks to an incredible group of people that do incredible things on a daily basis. I just have the luxury of working with them. So that's on my report. And if you want me to, if y'all don't have any questions of me, I'll go directly into our department update, but I'll leave that discretion to you, Mr. Chair.
Anybody got any questions, comments for Robert? You're on.
Okay, let's go into a little bit of the department update. As you all know, what we have done under our current chair's administration is we have put together every month an update for you all. And in that update, we give you inside information about how many employees might be in a department, what the department does. When you're a size organization of this magnitude, there are a lot of departments, not unlike some of the places you all came from before this, where there's a lot of people doing a lot of things. We try to use this 15-minute segment to give you an idea. This one's a little bit different. You can't tell on Dorothy DeBose's face or DT Nguyen's face that they have historically been blue in the face telling staff what to do. They currently have nice toned complexion to both of their faces, but there has been a time when both of them have said, please do this. And we either didn't get it right or we weren't sure how to do it. Today is our first, and that's at no fault of anybody. We just weren't getting it right. Today is our first step in trying to communicate to you as board members some of the things we want to try to do. I had the opportunity to meet with DT Nguyen and a staff that he has, and I was so impressed with the 3 people that he introduced me to about how we can begin to segment our population of connection patients. How do we manage connection patients? We on this board and we on this staff are literally going against 110 years of the way we've done things. And the way we did things is, if you look at the etching in the cornerstone of the building, which is now the building next to Bass Hall, where JPS first was located, it will tell you that we were here for those who couldn't go anywhere else, basically. And we're a lot more than that. And we're far more than that. But we've had about 110 years of not really managing the population we're trying to take care of. We've never asked ourselves the hard questions of what's our utilization? How many people utilize our services and how many times do they utilize it? How much are they costing us? Well, we might be able to reduce that cost. Because if we reduce the cost of patient care to a connection patient, we offer more care to more patients. So every dime that we save, we get more of an opportunity to help more people. This is not money that goes to the bottom line. It may well go to projects, but it's really going to go to providing more care. So when we met with you all about 6 months ago, what we wanted to do is we wanted to put together some focus groups. Again, and DT and Dorothy, if you all get tired of me mentioning your names, just mute me. But you all talked to us a lot and told us what your thoughts were. And the thought that was overwhelming to us was, what do people think about our program? How easy is it to get into? Is it in my language? Do I understand it? So what we did was everything that you're going to hear today in these 2 reports, and they're different. They're not necessarily connected. It's not one report. But the first report is looking at focus groups. So Michelle and Rory and members of the finance team put together focus groups for people that are using the connection program and ask the question, is it usable? Are we doing what we want you to do? Is it cumbersome? Is it hard? Is it challenging? And all we got is raw data. Now, if I could be so bold, let me challenge you as board members. Today's report is not to write the new connection program. It's not even to fix the connection program at this point. It's to listen to hear what we heard. It's to say, in the focus groups, they told us this. We're going to go put that back and think about what we need to do and talk to you about board members about how we change and how we look at that. We're going to talk with you all in the second part, and that is the actual eligibility and the enrollment parts of this. We're going to dissect down a little bit and look at the region of Tarrant County and look where our utilizers are coming from. Look where people who use connection are located in the county. Is it disproportionate at one end of the county or the other end of the county? So we picked key zip codes and we began to look at that population and we began to look at how many were utilizing it and for what services they were utilizing it. Again, you all can look at this report today and you will have a myriad of suggestions and ideas, very much like the myriad and suggestions that Karen Duncan had when we first gave her this report. And after about 3 minutes, we had to say, Dr. Duncan, with all due respect, stop. We're not going to fix it right now. We're just telling you what's in this report at this time. And Karen, as she always is kind and looked at that and said, oh, okay, so this is just a dip into the pond of some of our data. We may not be collecting it right. We may not be doing anything right. But David Mendenhall's team and our finance team began to look at where our data is. We have a sea of data. We threw one line with one hook into the ocean to see what was there. We didn't boil it down. So what we're going to do today is Michelle and Rory are going to talk to you a little bit about what our first steps. This is in response to what we tried and what we heard from y'all 6 months ago. You all told us before, but we heard about it 6 months ago and we said, let's begin. So today is that process. So we're not trying to rewrite it. We're not trying to fix it. We're just trying to tell you, this is our first attempt to looking at a few bits of information. We're now going to try to figure out how to enhance it, and we're going to listen to you all, and some of you who are particularly in that industry, and we're going to listen to how we fix it and how we move forward. So Rory, Michelle, it is all yours.
Thank you, Robert. And members of the board, we really appreciate the opportunity to speak to you today. And, you know, I'm not a long-time JPS employee. I've been here less than 3 years. But one thing I've become keenly aware of is just the commitment to the mission here and the care for our JPS Connection members. There countless times our board has inquired about the quality of care, the timeliness of care, how they receive care. Rarely does a meeting go by that we don't discuss the importance of that. And so Robert did a great job teeing up that discussion that we're going to have. That first topic is focus group. So I really had to hone in on, well, what does that mean? What's a neat buzzword, but what does focus group mean? What's its purpose? And its purpose is, it's just to make a product or a service better. So that's really how we went at this. As Robert said, we may not be able to solve all the problems right away, but we at least have a great list and some feedback from our patients to make things better. We realize the importance of that. We know that we have to constantly be looking for ways to improve and increase the member satisfaction. That they deserve that. They deserve everything that we can give to them. And so Michelle's going to go through the bulk of this presentation. I have the privilege of working with her side by side. She does a fabulous job. My only fear, she had such a good job doing focus groups that she wants to change her role and get out of operations and do nothing but focus groups. Honestly, she loved meeting with our patients. She took this on had a wonderful experience, and she's going to tell you more about that. So we're going to go now to the first slide. I'm lucky. I just get to hand the torch to her and let her do most of the talking. So Michelle, it's all yours.
Okay. Hi, this is Michelle Haynes. I'm the Director of Eligibility and Enrollment. I'm sorry, I don't. Okay, next slide. So basically, let me just start off telling you, as Roy mentioned, I had a tremendous time with the focus group, and I did ask if I could actually switch gears, because it was such a pleasure to meet with our patients after a whole year of not having that patient contact, to actually engage with our patients and dialogue with them. I felt honored. So what we did focus group, and we did surveys as well. So we wanted to do both so we can maximize the amount of feedback that we receive from our patients. So the focus groups that were conducted, we did English speaking for our English speaking patients. We did for our Spanish speaking patients, Arabic, Vietnamese, and then patients experiencing homelessness. Next slide. The first thing we did was send out a survey. We sent out we selected randomly patients to send our survey out to. It was close to 7,000 patients that we surveyed. We received about 350 responses. Those surveys went out, and once we got our responses back, we kind of digged into the responses on the application process, the questions that were asked. On this slide is what we have. So we asked questions similar to, is the application easy to complete? Do you have enough documents? If you did not apply, why? We talked about the approval denial rate. We want to know who was approved, who was denied, and then why you were denied. We also touched on care-related questions. Where do you go for your care? If you attend the emergency room instead of going to the clinic, we want to know why. We also had some communication questions in there as well, because we were trying to get a good group for our focus group. So we asked out of the patients that surveyed, if they wanted to participate in our focus group. Next slide. So we have a couple slides here that we're taking directly from the survey. This slide touches on were you approved or denied. So as you can see, we had about 89% of the patients that took the survey were approved, and about 11% were denied. Next slide. This slide talks more about the application barriers. The application barriers. So if you did not apply, why? So we were really wanting to understand why people were not applying for the program. So if you can see on here, the highest rating or highest barrier was, I did not think I would qualify. Around 31% of patients didn't realize that they would qualify for our program. And so what that got me to thinking is that, maybe most of our patients don't understand that we screen for more than just JPS connection. So when a patient comes in and they're submitting the application, we're screening for different services as well. And so I'm going to talk about that a little bit deeper into our presentation. But that was one of the biggest barriers. The next barrier was I did not know about JPS connection. And then the third one that we thought was really significant was I just forgot. So a lot of times patients are going to receive, self-pay patients receive the application during a clinic visit or at the ED. They're going to get that application and life happens and they just forget to apply. Next slide. So the focus group. This was by far my favorite thing this year alone. Again, I had a tremendous time meeting with our patients. I met with the 5 groups of people, and we got a lot of consistent information, but we got different information, which was quality information that I would have never thought of. Every year we try to improve on our program, but I think this is the piece that we've been missing, that patient feedback. We got to see it from their eyes, how they perceive our program. And we got a lot of good, positive feedback. And then we got our opportunities as well, which I perceive as positive feedback as well. So I'm gonna go over just a few of the positive feedback that we received. Prescription coverage. Our patients definitely stated that they could not afford their prescriptions without JPS connection. They absolutely love the telehealth visits, being able to visit with their doctor from the comfort of their home. And across the board, in every single focus group, they talked about how we have good doctors here, and they really enjoy the service and medical care that they're receiving. Some of the direct patient statements that we have here, JPS connection allows me to receive my medical attention when I need it. I feel relieved knowing that I have coverage. So those are huge statements to me. I know we're doing a great job with our program. But when you hear it from a patient, it just takes on it takes on a different meaning for me. Next slide. Okay, so here's our opportunities. Our opportunities, which I want to say are positive feedback as well, because I get excited because I know that this information we're going to take and we're going to make some additional changes to our program that's going to benefit the people that we serve. So in the application process, our patients want to see that we have, they want to be able to apply online. They want to be able to submit their documentations online. They want it that simple. They want to just be at home, apply, submit, and be done with it. Also, language simplification. So let me go a little bit deeper on this. In one of our focus groups, they had expressed that, and we do have applications in different languages, but they express it's not the application in a different language. I mean, they love it being in their language, but they want it in a different format. So certain groups would like it formatted a little bit different so it could be a little bit easier for their community. So I thought that was very interesting. So we're going to work on that. And wait times for submitting applications. This piece of it speaks more to our clinics. So we have eligibility staff. We have 2 centers, and then we have eligibility staff in our clinics. So what our patients were saying is they want to be able to drop off their applications, not necessarily stay for an interview, but they want to be able to drop off their applications and have someone review that application before they leave. And so right now at our clinics, we have maybe about 2 specialists at each clinic, but they don't have the, it'll take a little bit longer for them to review the application because they're actually processing applications as well. So whereas at the centers, we have a support staff is what we call, or clerical staff that actually triage those applications and go through it. So we're going to look into putting some extra staff at these clinics to see if we can help with that process. One of our patients talked about being able to complete that application while they're in the emergency room and they're waiting there. So, of course, when patients go to the emergency room or they're going to any clinic visit and they're self-pay, they're going to be given an application. What they express is they would like to be able to submit that application while they're in the ED, in the urgent care. So this particular patient received the application while she was in the emergency room, but she was told she had to submit it back to the eligibility department. So they would like that opportunity to be able to submit it there. The next section that brought upon opportunities were the benefit and cost. So across the board in every focus group, they touched on dental services. They would like assistance with dental services. They will also like additional copay assistance. They also talked about vitamin and over-the-counter medication assistance. And one other thing that they mentioned was we have a large population that don't have a smartphone. They don't have a computer access. So they're looking to get updates from JPS about the different services we provide, or just things changing in JPS through maybe a newsletter, maybe something that we can mail to their home, or maybe something we can give to them when they come to their visits. So that came out of there. Some other opportunities that came out just for the network in general that we identified in some of our focus groups was the time frame it takes to schedule an appointment. Transportation to get to appointments. Some areas don't have public transportation. And they also touched on the website being in different languages. They would like to see our website in different languages. One of the questions that we added to our focus group was we asked them if they could name something outside of their medical care that would help them with their overall health. And across the board, they named fitness. I thought that was really, really interesting that they named fitness being something that they would like to assist them. So they asked for maybe a health club discount or maybe nutrition or cooking classes. So that's some of the feedback that we received. It was a very humbling experience just to be in the room with these patients because they were very passionate about helping. They were very appreciative about our program, about the medical care that they receive here, about the doctors. They were really excited to be able to voice their opinion. And you can generally tell that they really wanted to help improve this program. And they were honored to be chosen to participate in the focus group. Next slide. Next slide. Okay, so my next slide, this just speaks to what I was talking about a little bit earlier. We offer different services and eligibility that I think we probably need to do better education on. So we do screen for active insurance. So anybody that comes in as self-pay, we're going to screen to see if they have any active insurance. You'll be surprised at how many people we find that may have insurance and not aware of it. So that's usually like our young adults is still covered under their parents' insurance and didn't realize it, or it may be an employee who's covered under their sponsored employer program and they wasn't aware of it. But we do find active insurance. We also screen for Affordable Care Act. All the staff and eligibility are certified applications counselors. And so we do assist in enrolling into the Affordable Care Act. That's actually going on right now. It has had an extension to August 15th, so we're doing that currently. We also have two vendors, eligibility vendors. We have MedData and RCA, who assist us in screening for Medicaid, disability, crime victims. And so we screen for that as well. Of course, we screen for JPS Connection. We also screen for different grants as well. So we screen for Title V grant, Child Health and Dental, Prenatal Dental. We screen for Ryan White. We screen for Family Planning grant. So there's a multiple different programs that we screen for in eligibility that I don't think everyone is aware of. And we simultaneously do that as we're screening for JPS Connection. Another resource that we do and we offer in eligibility, we do a lot of community outreach and education as well. And so this in a nutshell is the feedback that we received from our focus group, from our surveys. We are definitely, as Mr. Early said, going to take a deep dive into these results, and we're going to see how we can affect change. Are there any questions?
Before y'all ask Michelle questions, and Michelle, thank you. There are two things that Michelle was concerned about. One, the speed at which she spoke, because she says that when I give presentations, I tend to speak faster. I don't think any of us would think you spoke fast. Well, maybe a little. And then the second part of it is she said, where do I end my presentations? To that point, Amanda, we have historically not put the departmental updates on the portal as information to y'all as staff, because it's information that we give out just at a board meeting. It's not that we're trying to hide anything, protect anything, not provide information on something. It's just been a basic update for you all. We treated this one the same way. Certainly didn't mean to cause a challenge or a problem. All of this information will be available to you. It will all be out there, but for the preliminary nature, for this, we were hoping that the initial dialogue of this, because we only know initial results at this point, was not going to be the deep dive that Michelle just alluded to that we don't know. So to that point, we didn't put it on the portal to begin with, because we as staff were not prepared for a deeper dive. But we will certainly put this information on the portal so that you all can look through it, as we always do after the end of each report. And then you all can say, what do you think? If you as a board want all that information in advance, we'll try to do that. But the department meetings have really just been informational for you all. Then you all take a look through it and tell us which direction to go. Trent, to your question about how many of our connection people do not have access to cell phones, we didn't ask that question in that detail, because it's not so much do you have access to a cell phone, it's do you have access to a cell phone with data. We were trying to figure out, because there's a big difference between owning a cell phone and be able to make phone calls on it and having a cell phone with a data plan. So we will ask those questions and we'll do a deep dive into that. But at this point, we did not ask. That is an anecdotal comment that we know that we have a variety of folks in our program that do not have access to a data-driven smartphone. Not that they don't have smartphones. In fact, again, anecdotal, we have a good number of our patients that have phones. They just don't have a database to their phones. Trent, I'm not trying to be evasive, but we haven't done that deep dive question.
Can I make a comment, Dr. Weber? It's Rick Miller. I was really pleased to see on Michelle's presentation that our patients are interested in fitness and nutrition. And as you know, it is quite expensive to join a fitness club. And McDonald's here on JPS is a heck of a lot cheaper than having an organic chicken and arugula salad. And so if you look around JPS, there's donut shop and kolaches, and but there's not a tremendous amount of advertising for fitness and healthy food. And so I'm encouraged by the results, and I'm looking forward to trying to find ways that we can help our patients with getting into better shape, eating better, and reducing their admissions for medical problems. Just wanted to know your comments on that, Michelle.
Oh, I'm sorry. Absolutely. As I mentioned, when we were going through the focus group and we asked that last question, it actually surprised me that they really were interested in fitness and they wanted to work out, they wanted to see the discount club. So I think being able to offer something that like that under our umbrella would go a long way with our patients. I think this is something that I would have never thought would have came out the focus group, but I was very surprised and pleased that it did come out the focus group. A lot of the things that they shared with me, their stories and their history, it was very interesting to hear from them. And like I said, I think this was needed. We haven't touched on the patient experience as far as JPS Connection, at least, since I've been here. So I thought it was very needed, and I am very excited to see where this goes from here.
So I just want to make a mention here that about that comment right there about surprised that our connections patients would be interested in fitness and also whole well-being. Being poor and wanting to be fit are two separate different things, or being economically disadvantaged. So I think that we need to, especially when we're doing these focus groups and working through, we have to keep that in mind with our individuals. We have to take off our own middle class bias and really let the people tell us what they're really interested in. The reason that I brought up to have these specific presentations to us before is because, Michelle, you did a great job. Thank you so much. That's really valuable information, but it does go really quickly. And Robert, you wanted our input on this. So in order to be a good and the best board member that we can, I wanted to be able to have that information. But I think when we're talking about, especially with our connection patients, understanding that fact, that they do have this idea of whole wellness, and we want to be able to bring that. And I think that the question in place is to be able to really move that forward. And it's not also just lack of choices sometimes, lack of opportunities, especially when we're talking, as we talk about social determinants of health all the time, of where the food deserts are, where are affordable housing opportunities. Everybody is resourceful, creative, and whole on their own. And we have to think of all of our patients in that way. So that's my 2 cents.
No, and that's appreciative. And I understand that. And I think none of that is anything that one, we want to take for granted, nor do we want to come up with any conclusions by the lifestyle we live. I think this is the very beginning of what will be far greater details. And even to Trent's comment, is we chose at this point not to go to an outside source for a rather more sophisticated questioning and going deeper. We kind of wanted to know what was there. And to your point, Amanda, yeah, I mean, we definitely want your input. We're going to want your input a lot as we go through this process and try to figure out the directions that we take and how we want to go about doing it. So we'll try to make those best judgment calls for you all so that you can know that you've got the best input and we can get the best input as to where we go from a staff standpoint. So I appreciate your comments, and I do appreciate very much the fact that all of us are going to be biased in some way about what our thoughts are. And those thoughts are oftentimes wrong about what people think, what they use, what they don't use, how many have cell phones, how many don't, how many want to exercise, how many don't want to exercise. I don't think your wealth or anything has to do with wanting to exercise or not wanting to exercise. I think basically all of us want to be in better health, and JPS has the tools to help make people be in a place of better health, and we want to utilize every tool. So, Amanda, your comments are well taken. Thank you.
This is Reverend Emerson. First, I want to say it was an excellent report. It was a rarity to see that the health system asked those who participate in it how they feel about that health system. So I thought and feel that was really a plus to get the comments from those individuals who frequent our JPS connection. My question is to Michelle, that you gave points, positive points, some things that they were liked and were excited about. My question is, were there negative comments that had the team to look at how we deliver our services that you had not looked at before? Were there any, kind of eye-opening negative comments? Because I didn't really see or hear that, and it'd be interesting to see if something came forward that made us really look at our system to see how we deliver.
Reverend Emerson, so we just didn't name it negative comments. It was opportunities.
Okay.
So that's where we put where it was not as favorable for us. But the eye-opening thing that I think I would want to point out was that language simplification, where the patients are looking for us to change the format. For different focus groups would like for the application format to be a little bit different for them, so it could be easier for their community to process. And so that was the thing that caught my eye right away. Other things that was an opportunity that they were really concerned about dental. Really concerned about having dental coverage. And so they gave us in-depth stories about things that have happened and how they couldn't get their dental care because they couldn't afford it. So that came out of those focus groups. Some of the other things, the online simplification or submitting documents, that's stuff that we're working on. So that wasn't really new, but the language simplification of the application and the dental was something that they really felt strongly about, and they wanted to see some change.
I noticed that one thing you mentioned, because I know I've asked about this, and Robert told me to go sit in the corner and stop. But what I think it would be a great idea.
Don't even go there.
I think it's a great idea if we could afford to do it. Is that newsletter at least to the connection patients, because if there's some type of communique to them, and they will do word of mouth to those who are not connected to share what they're receiving from JPS. So I think if we could look at something like that, I think that would at least also help. Yeah.
Yeah. Yes, I totally agree. I think the newsletter for our connection patients about anything changing with connection and the network as well, because they were looking for, because we started to talk about different programs at JPS, and they were looking, they want to be able to get that information as well, not even if they can't get on the website or go to Facebook, they want to be able to get that information. So I agree. I do think we're going to work on some type of newsletter, but that will probably be a combination with other departments as well.
One of the things, first of all, it is never, ever my position to correct a pastor. I never told Reverend Emerson to go sit in the corner. And secondly, I did want to say, this report today really is our efforts, and you can mark this day in the first day that we got to the point where we started transforming the Connection program from episodic care and utilization to population health management. It doesn't have the answers, and I can promise y'all this meeting could last 2 more days just talking about Connection, its transformation, where we're going to go. And when you all see the next slides that talk about where our patients come from and what they're utilizing and services, you all may want to set up a cot because you could be here for a long time. And we appreciate that. And we appreciate that interest and that excitement. But really what we're trying to do is say, for years, through a variety of sources, we've collected data. We don't retrieve it well. We're not in that realm. And when this organization started 110 years ago, nobody was thinking about taking its Connection population and trying to make sure that you manage that health, you enhance that health. We were just trying to cure and help. And that's all the generations all before us have done. And that's what generations of boards before you all have done. So our goal today was to let you know that we're able to pull some of that information, but we're going to use a whole lot more sources in the future to figure out how we begin to transition our Connection program from an event, people walking in the door saying, I need care and I need health assistance and I need financial assistance, to a program where we actually manage people's health. And that's where the future of JPS is. The last thing I'll say is, and this is not to put pressure on Trent and Steve and Dorothy and Amanda and Ralph, but the only 3 people that are here are Chuck, Zim, and Roger. And we had a full plate of cookies, and now that plate is significantly reduced. That's all I'm going to say on the matter.
I just want to mention one other item in reference to the Connection and when I mentioned the newsletter. Way before we were ever talking about or discussing or had any impact with the pandemic issues and concerns that came forward, we were at a quality meeting, and DT always kids me with it now. But at that quality meeting, Chuck was chair at that time of the quality. Staff came and did a presentation on hand washing. And I was just sitting here thinking, wow, it would have been good if we had a newsletter just to have advertised that way back when they were teaching us about proper hand washing. And I think that's just kind of the things that I think would be a plus that we could put in the newsletter as we go forward.
Yes, sir. Yes, sir. No, I appreciate it very much. What you all are going to see, and we're happy to go through any of the questions, what y'all are going to see next really is a breakdown of where some of our Connection patients go, where they're coming from, what services they utilize. Again, to your point, Amanda, we will send this out to you all for you all to dissect a little bit more. Get us ideas. It will sit in front of you. You can think about it. You can write notes on it. Get it to us and say, could we have more information like this? Or this wasn't very helpful. Or could we bring in a third party to provide us even greater assistance for this? We're just kind of giving you all an idea of what this looks like today. And I'm not trying to minimize it, but you will see a lot of that when we get into this next section. This next section could have been dissected one of 75,000 ways. We just wanted to show you what some of our data retrieval can do. And you all can say, that's not very helpful. Or, yep, that is helpful. I wish I had more. Or continue to do that same thing and present it to us on a quarterly basis. So I'm going to turn it over, I believe, to Sharon, because Rory and Michelle are not making eye contact with me any longer. So I'm going to turn it over to Sharon.
Okay, thank you. So as Robert introduced us, please understand that Robert, can you mute yours? As we start into this presentation, this is just one of literally hundreds of different ways that we can look at the connection data. As you probably have surmised, this is about historical payments and costs as I look at high cost utilization. As our clinical integration team begins to build, this is one idea of how we might start to proceed and look at our high cost utilizers, there's a heat map of sorts that are in here to talk about 6 zip codes that arose when we started to look at a year's worth of data. And I think this is a great starting point, but again, there will be more questions that come out of this presentation. But again, this is our first kind of a different type of data pull as we really start to look at the location of these patients and what their primary diagnosis was. All of this, again, is based on claims and costing. So I will try to kind of lead you down how we took the overall connection population and started to narrow that look quite a bit. So if we can go to the next slide. So as you know, we have, a large number of connection patients, and a small percentage of those don't actually access care once they get approved. So the first narrowing that we did here is we just took patients who had at least one claim during fiscal year 2020. So that ended up being just over 35,000 unique patients. So also remember, patients roll on to connection and patients roll off of connection. So that was our first look. And the per member per month amount that we were spending, what it cost us on each one of these patients was about $590 a month. There's also, so we took all of those unique patients and we sorted them from high to low for fiscal year 2020. And there was a natural break of about 10% of the highest cost patients. And out of those 10%, their monthly costs averaged about $3,300 a month. So we try to look, okay, where is that 10% based on their zip code within Tarrant County? What were some of the most common diagnoses? And that helped us determine maybe what some of our high cost drivers are. So if you want to flip the page. So Dr. Weber, who's in the room with me, asked if this was based on costs or charges, and these are based on costs. So those costs are accumulated for pharmacy, for any type of service that a patient accesses here at JPS. So when we look at, if we can go to the next slide. Thank you. So the top 10%, again, so here forward, we're really just looking at those top utilizers again. There were about 3,500 patients that accounted for almost a quarter of total encounters and 60% of total cost. Again, not charges, but costs of the entire population of connection members. So encounters could be, as I mentioned, an ED visit, it could be a primary care visit, it could be a lab draw. So many, many different types of encounters, but this is accumulated based on the costs of those encounters. So, and again, we're really starting to talk about that top 10% again. Next page. David, can you flip the page? Okay, so this is the heat map that I was talking about. A lot of that top 10% really ended up in 6 counties. And this is a hard map to see because of the yellow lines, but we've defined these 6. 76102 is downtown. Our True Worth Clinic sits in that location. We also had 76119, which is the Stop 6 clinic. Eastern Hills popped out, Western Hills, Wedgwood, and White Settlement. So I'm going to start to look at each one of those 6 zip codes here on the next few slides. Next slide, please. I'm going to spend a little bit of time talking about the layout of this slide because the next 5 slides are exactly the same for different counties. So I just want you to kind of see what all is here. So for our True Worth, which is highly impacted by patients that are experiencing homelessness, you can see the diagram of MAP, which is the area that we're actually talking about. You see that in the diamonds or the stop signs down below, you have per member per month. Again, the cost, the average cost per month that each one of these patients is costing us. And it's not the $590, it's $2,100. They had approximately 3,600 encounters over the year. And there are 319 unique patients in this zip code. When we looked at, on the left side of the page, these colored bars, probably more helpful for some than others, but these colored bars will be consistent throughout the presentation. But our number one cost for these patients was behavioral health. We also had complications, which is mainly wound care and drug abuse in this population. The third most common and costly was sepsis. We also had chronic ulcers and heart disease was number 5. And as we move through these presentations again in the next 5 slides, you're going to see a lot of these in different orders again. Any questions on the initial layout of the slides and what each one of these components is before I move on?
Hey, Shem, I just have, can you go back to the last slide right quick? Because if it's this 300, sorry, the previous slide from that. The one where it's a 24%. So 24, yes. So 3,500 patients encountered, 24% of total encounters, 60%. Okay. So you can go back to the first slide, the last slide. Okay. So those 319 patients that are in there, you're saying about, on average, overall, about 24% of those are continual repeat patients?
So this 300, yeah, this 319 are part of that 3,500 patients and are concentrated in this one zip code.
Yeah. Okay.
There's a lot of numbers, but I think when you step back, after I get through the next couple of slides, it's going to start to tell a pretty strong story of these high utilizers.
Thank you.
You bet. The next slide, please, is going to talk about 76119, which is includes our Stop 6 clinic and South Campus located right in that area. Again, the per member per month cost is almost 3,800. Encounters are about 2,800 for 214 unique patients. So each patient has 13 encounters. Again, that could be an ED visit, it could be a surgery, it could be an inpatient stay. But the number one diagnosis in this zip code is hypertension and heart disease. We saw that on the previous slide. Also, wound care from head injuries was number two. We also see sepsis throughout each county. Oncology is the fourth, and acute GI disorders is the fifth, which also includes things like cirrhosis and diverticulitis. On the next slide, yes.
Shan, am I looking at this correctly? If we spend $37.68 per member per month for our 214, we spend about $9.7 million on 214 patients.
That is correct.
Oh.
It is our top 10% utilizers.
Okay.
Now, this includes DT inpatient costs. It's not just what we pay through what we traditionally look at as our professional fee connection through medical services reimbursement. It will include pharmacy, professional fees. It's kind of a all-inclusive, fully costed look.
Oh, including post-acute care and everything else we cover.
Everything else that any care that they access here at JPS.
Got it. Thank you.
Yes, sir. If you go to the next slide, we are looking at Eastern Hills here. I-30 and Loop 820. Oncology is number one. Hypertension. Again, you see GI, cirrhosis, ulcers. Number four is urinary complications and injuries. And number five is behavioral health. There's about 186 unique patients in this zip code, running just under 3,000 per member per month. The next slide is going to be Western Hills. Again, oncology is number one. We have heart disease. The GI is number three. Diabetes is number four. Diabetes showed up in two of our six counties. I'm sorry, two of our six zip codes within the county. And behavioral health is number five. There were 106.
Sharon?
Yes.
My apologies for interrupting. On the 1 through 5 on the left-hand side of the screen, those are ranked in that order based on cost or in encounters?
Cost.
Okay, so it wouldn't be
cost.
surprising that oncology would be high, right? I mean, that's just a high,
It would not.
inexpensive. And I know there's 100 million ways to slice and dice the data. I would love to see number of encounters too on these sometime. This is really fascinating data, by the way.
Correct. And remember, we're not looking at the total connection. Again, there's, this is one of many different ways to look at it. These are just the top utilizers. But yes, that's a very good point. So the next slide is going to be the Wedgwood and South Hills zip code 76133. Again, Steve, to your point, not surprisingly, for those that have cancer diagnosis, that is going to be a relatively high cost treatment. We also have sepsis as number two here, heart disease, diabetes, and behavioral health round out the top five. There's 140 unique patients in this area with about 2,000 encounters. Next slide is White Settlement. And this is the last of the 6 high utilization counties for the connection, top 10% of cost. Here we have about 121 unique patients at just under 2,000 encounters, and it's right above 3,300 cost per member per month. Oncology, again, is the number one. We have heart disease, diseases of the musculoskeletal system, which is really pain management, lower back, and osteoporosis. That is kind of unique to that zip code in this presentation. We also have the GI diagnoses, as well as disease of the respiratory and nervous system, which includes COPD, seizures, and Alzheimer's. So if you look at it kind of a different way on the next slide, this is by encounter type. So if you look, really the point here is across the 6 counties, True Worth is a high utilizer of our emergency outpatient. And anecdotally, I do not believe that that is a surprise, but there is opportunity there for sure. They're also higher in observation. But the other 5 zip codes are relatively consistent in the way that they access care, and it's mainly in our outpatient centers. So again, these are just the connection patients that have been utilizing care over 2020. That's a lot of information, and I'll be happy to take questions. Yes, DT.
And I'm just curious because usually MSK is in the top 5, and out of 6 region, I mean 6 location, we only have 1 that MSK show up. Is that because the other place is doing more pain management but not operation?
Actually, I don't have the information to tell you. I could probably make a informed guess, but I don't want to have to do that today. I think what this points out is it just gives us some very direct questions that we can go out and start to investigate. This is just a part, this is one way that our clinical folks can go out and start to target future areas of focus.
Right. Oh, it's good data. Thank you.
Sharon, this is Dorothy. On the first 2, I noticed that we had amputations and in there, but I didn't see diabetes. Usually when they're amputation, they have a higher number of diabetes. Was that just the primary?
Yeah, so we each transaction, we have to select it on criteria. So the way that we sorted these was by primary diagnosis. That could have been a secondary or tertiary diagnosis, and it's probably an underlying condition. But based on the coding of that actual claim, this was the primary diagnosis. So to your point, you know, there was something that was going on. Also, we've talked about the cancer diagnosis being the highest cost. Are we sure that we're doing screenings early enough? I think that will be a road that the clinical focus goes down.
Yeah.
So are we providing the right care at the right time at the right place is the basic questions.
Right. Are we taking opportunities of prevention and management, right, to their maximum, diabetes in particular? So remind me again what sepsis is. I forgot.
So sepsis is really just any type of infection that occurs. There's a clinical person that can probably take that question better than I can, but it shows up consistently throughout the presentation. 3 of the 6 counties actually have that as a high utilization diagnosis.
I think what we may see also is the unique year of COVID. All the unnecessary surgery has been canceled.
Mm-hmm.
You see more of cancer or some other urgent care emergency than anything else.
I just want you all to know the confidence that we have in you as a board and you as a board having us as a team. The chairman of the finance committee is asking a sepsis question to the CFO, and he got an answer. So that just should give you an idea of the diversity and the magnitude of this team.
Yeah, I should say I'll be happy to answer any non-clinical questions or punt to someone else in the room, but I think this really gives us a different view than we've had in the past as we start to refocus on managing this population.
I agree. You know, Sharon, the question I have is I wonder how this data compares to a normal, or not normal, but other populations that are being managed, you know, whether it's a private payer, you know, if we could look at them, profile our connection patients against something like that, if we're out of whack or if we're kind of consistent, and it'd just be interesting thought process.
Well, it'd also be interesting to see our entire population broken down by zip code. Yeah, I think what y'all are discovering in today's report is just an idea of the preliminaries, what we think we might be able to present. We're going to work with a couple of different groups to figure out how to make this, one, more manageable information, more meaningful information, and then help us as we decide buildings that we correct, services we provide, what we do with the claim as we go through the structure of a claim, and a variety of other things into what we actually do to provide the best services to all of our population, those that might need some type of assistance with their healthcare and those that are commercial payers that need no assistance. So this really is our attempt as a staff to begin to tell you today's, for us, the first day of the rest of our time in calculating information. So again, we will get this information to you. We know that y'all will decipher it. We want you to. We want you to give us your feedback, your comments. We just didn't want to give out, a lengthy report if we were way off base and it wasn't even close. So to Dorothy and BT, I hope we've begin to answer some of those questions so you're not hearing the same reports that you've been frustrated with. And we hope that we're addressing where we need to go with a lot of advancement as we head into the future.
I have a question.
Yeah, go ahead.
Where are we feeding this into the strategic plan?
It's very much a part of the strategic plan as you start looking about where do our patients come from and what are their needs. So, for example, when you start looking about the amount of physicians that we're going to expand to, service lines, scope of service, this all speaks to a lot of those very questions, and that is what type of services we should be planning. In addition, I believe it speaks very strongly to any allocated funds, whether they're philanthropic or bond type monies. And Trent and I have discussed this. What kind of building should we be building? Because it may not just be traditional. We may be missing the mark on many of our patients. So I think it speaks directly to the strategic plan in a lot of ways. Mr. Chair, that's all of that report that we have for you. Again, if any of y'all have questions, we're happy to, but I do feel that when we get the report and you have time to look at it and go through it, you'll have more questions, which we want and we're happy to have. So let's go through that. And again, if y'all have any more questions, we'll be happy to go. We'll be sending those out to y'all as well.
Are we going to have board designated time to discuss this stuff every month?
One of the cool things is you have two titles, Dr. Weber and Chair Weber. And both of those, particularly
sepsis.
and Chair Weber allows you to define what you want to do with board time in regards to this, and we as a staff will accommodate.
Got it. Anybody else? Comments? Questions? Seeing that next thing I have on the agenda.
This is
I'm sorry, Dorothy. Go ahead.
I just want to tell Robert and Sharon, I do thank you for giving that beginning data. That is something that I think we can move forward with and really answer some of the questions. And in our strategic plan, it will also help us in our our care models that we're talking about setting up. And one of the deals that I hope this will help us come up with a plan to reduce the number of, we got 24% in that high. You don't want the rest of those to move over to be high utilization. So what programs, how do we address their risk so that we can keep it low? So I'm excited about it, and thank you for presenting it.
Thank you, Dorothy, very much. Thank you.
Now, this is a good first pass.
Yes, it is. Thank you. Thank
No
you all very
question.
much.
What I saw is a dialogue between a chair of finance and CFO. I think that's a good start because most organizations they're trying to solve they're trying to boil the ocean. I think strategically, with the right resource focus, I think we can go a long way from that perspective.
PT, we normally just talk about who's better, UT or A&M.
Well,
And we all know the answer.
That discussion doesn't have and know the answer to that, yes.
How about we find
Steve, you should look
a better one, University of Houston?
Yeah, Steve, you're more politically astute than that. You should just got about that.
Okay, anybody else? Comments, questions, etc.? I have Roman numeral 8, report from the Medical Executive Staff Committee. That'd be Cheryl.
Hey, thank you, Dr. Weber. I appreciate the opportunity to address. We don't have any policies at this point yet, but I did want to give a verbal update for the board, if that is okay. Just to go over our continuing organized medical staff quality oversight functions, we did approve the minutes of the patient safety and quality governance, which had been submitted to MEC 2 days ago. And we also had a very detailed and good informational report from Dr. Elliott and Academic Affairs regarding all of their activities. It was their annual report given to us. And then we did also review and approve the medical records and utilization review committees. In regards to education of our med executive team, since our retreat that we had, educational retreat that we had in the fall, since that time we have had some free webinars that were made available to us by our bylaws committee subgroup for further education of our medical executive committee. And we're planning on an additional retreat in June for education and training in peer review protection and privileging updates. So we look forward to that as well. Had some very robust discussion last time and very excited about continuing to have retreats for the medical executive committee. And then finally, a brief update on bylaws. The bylaws committee has now also reviewed articles 8 through 9 and 12 through 15, made up of the APP staff, officers, elections, meetings, authorization and conditions, general provisions, and adoption and amendment of the bylaws. Articles 10 and 11 are being finalized next week, and they involve organization of clinical departments and divisions along with medical staff. And our bylaws consultant, Erin Mullenberg, with the Pulsanelli Group, has been in contact with General Counsel and will continue to be in contact with General Counsel, reviewing the bylaws prior to the active medical staff vote, and then voting by the Board of Managers will take place subsequent to the active staff vote. We did have to delay it by a month because we were hoping to have it completed by now, but we were unable to, and that was at the request of our consultants. And also Erin and Daphne we'll get together about the best way to move it up through the board once the active staff have voted, whether it's directly to this committee or up through the government. So that concludes my reports. I'm happy to answer any questions.
Okay. Comments, questions for? Don't see or hear any, Cheryl. Thank you very much. Next thing is Roman numeral 9, and it's got 3 items underneath that that require board discussion, update, deliberation, and action. And the first one is approval of the minutes to the services agreement with Prudential Retirement. That'd be Alex.
Hello, Chairman, and thank you for allowing me to come before you to consider approval of amendments to a services agreement between Prudential Retirement and Annuity Company and Tarrant County Hospital District. As you may recall, I presented the same amendment at the last Finance Committee, and a board member had a question. That question was related to the ability of employees to select individual stocks and or how fees might vary based on fund type selected. I answered those questions via email to the board, but I will share again what that answer is for the meeting today. And that is, I did confirm that employees are not permitted to select individual stocks. However, there are different expense fees associated with each fund type. This is very standard in the retirement and investment arena. And I would now like to ask the board to consider approval of amendments. I'd like to share some additional information with you regarding the cost that occurred last time, and that is we have asked Prudential for a reduction in fees from the last year's contract of 0.7%. There is no cost to the organization. However, the participants in the fund pay for those administrative and investment fees. We project those fees will be approximately $1,276,693.52. That number could adjust and fluctuate based on the plan size and the assets. 4 other quick points regarding this amendment. These are 3 separate agreements with Prudential that cover our 403B plan, our 457B plan, and our 401A plan. Secondly, this aligns with our people and stewardship pillars to make sure it's a user-friendly system, good customer service. Prudential has been a provider of this service for us for the past 4 years, a 3-year agreement with a 1-year extension. This agreement would move us into year 5, 6, and 7 of them being our provider for this service to our employees, and they've done a fantastic job. I would also just like to mention from a diversity, supplier diversity standpoint, this is an excluded category. However, Credential has reached out and connected with a diverse supplier and has agreed to commit to 15% of the contract to this diverse supplier. So even though an excluded category, they are having the minority supplier participate. And with that, I would ask if there are any questions.
I have a quick question, if it's fine. On the, as you said, they only have one fee, so they can't carve out bond as a separate category, because bond is very, very low yield. And by the time they manage that as a full portfolio, it's a one-time event when they purchase and sell. And, you know, on the individual one, you would be able to carve that out. On this one, they can't?
That's right.
That's interesting. The size of the organization that we have with the number of people investing in it, they should be able to carve out just a one for bond, especially for bond type thing, low yield bond type thing.
I do have meetings scheduled with them throughout the year. Yeah, quarterly meetings scheduled with them throughout the year, and we're more than happy to discuss that with them and see if that's possible.
So DT, I will say that they, you know, as an employee, you can choose which type of program that you go into and how you direct your investments and which mutual funds. So each mutual fund has its own individual charge or fee associated with it. Was that your question?
I can't hear DT.
Yeah, I think we lost DT.
I was on mute.
Okay.
So I was concerned about like the employee select municipal bond or something like that as a category. That's a one-time event. Usually people carve out because by the time you manage the whole portfolio, that amount can be very, very, add up to be, the fee can be pretty high when time you do that.
So the fee is not an overall fee. It's dependent on which fund that the employee elects to invest their monies into. They cannot buy an individual stock, but they can go into a small cap fund, a large cap fund, or you know, any number of bond funds. There's quite a few that you can select from.
Right.
So as I indicated, I will speak with Prudential and we'll see whether or not they are offering that to other organizations, and if we can see about that for future reference. And I will get back to you. But for this agreement, it's not possible.
Anybody else? Comments, questions for Alex? I've seen none. Entertain a motion to approve.
This is Steve. I'll move to approve.
Second, DT.
Second from DT.
Yep.
Any further discussion? All in favor, please say aye.
Aye.
Those opposed say no.
DT, no.
You got that, Suzanne? Okay. The next one is B, Patricia, with archival of policy MS 400.
Thank you, Dr. Weber. I'm here seeking approval for archival of our medical staff policy 400 on professional liability risk management. Well, with input also from our legal department too, we've also reviewed this and realized that this is already in our bylaws and will continue even as we seek our bylaws revisions at the current moment. So this is not a policy that needs to be in place at this time. So we'd like to.
Comments, questions for Tricia? Entertain a motion to archive the policy.
For approval.
Zim second.
Zim second. Discussion. All in favor, please say aye.
Aye.
Those opposed say no. Motion passes. The next one is Tricia again, the policy MS 900 credentialing allied health.
Thank you, Dr. Weber. And this is also archiving medical staff policy 900 on credentialing allied health professionals. We actually do not credential allied health professionals, but we do have advanced practice professionals. This is very clearly laid out in our bylaws, and that is where we go. So this is not an applicable policy, and we'd like to go ahead and archive it.
Comments, questions for Tricia?
I'll move approval.
Got it.
I'll
Is there a second? Who is the second?
That was me,
the other
Chuck.
Steve.
Simmons.
The other Steve.
Real Steve. The other
Real
Steve. The Aggie Steve.
All in favor, please say aye.
Aye.
Those opposed say no. Just as a clarification for the rest of the board, one of the charges that I was not hit with, but there wasn't any follow-up on the questions that members had at board meetings. And Suzanne has been trying to formulate them and get the answer out in the form of an email so that we don't have questions and answers just sitting time after time after time. So for DT and Alex, get that out fairly quickly so that we don't have to wait till next month. That was one of the charges that I was given, and I want to make sure it continues. Next one I have is number 10, committee reports and action. A, Finance Committee. Steve Montgomery.
Thank you, Mr. Dr. Chairman. We had a Finance Committee meeting on the 25th of March, considered many items, including the February financials that Ms. Clark presented. We also have, I think, 9 or 10 contracts that we put forward for the full board's consideration, and we encourage you to vote favorably for those. That's my report.
We have to approve that, correct? No?
I believe the financials are on consent.
Okay. Then the second one I have is the Human Resources Committee.
Well, thank you, Chair. We did meet on March the 25th. We had a presentation from Diversity and Inclusion that showed our vendor spend. Maybe later on in the year, we could bring that an updated report to the full board. On the consent agenda, we have about 10 policies. That ends my report.
Okay. Comments, questions for Dorothy? Anybody? Next thing I have is Roman numeral 11 is the consent agenda. And if none of them are any group not going to be pulled, I'd entertain a motion.
Mr. Chairman.
Yes, sir.
I'm not asking to pull it. I just want to express that I want to vote no on item H.
H. And that's the professional services agreement with Meadow Mental Health
Yes.
Policy.
I just, and I know I'm sounding redundant, but I just want to express my concern. I still think that we need to tighten up when it comes to those contracts. We're spending over $700,000, but that companies knew when they were participating, they were not in compliance or could have worked, I think, even more, put in more effort to be in compliance with our MBE, WBE policy, diversity policy. So I just wanted to express I'm voting no on that item.
Yeah, I believe that was the point of your discussion as well in the
finance
committee.
Right.
All righty.
Mr. Chairman, you should probably
Yes,
pull that item off and we have a vote on that particular item.
Okay.
So Mr. Fisher and
We'll
Mr.
pull
Chairman,
H off.
You don't have to revote on the item unless there's other objections, since you did have that on the consent agenda from finance. So that would be.
I can't hear Daphne.
Yeah, Daphne, you are too hard to hear, so you might have to get a little closer to the mic or just come on into the OPC.
Okay.
If you can, either which way, but we can't hear you.
Might have to run over there. Can you hear me now?
Yeah, much better.
Okay. I was just saying, Mr. Fisher and Mr. Chair, you don't have to pull it because it was approved in finance unless there's other objections. So you still had enough for the motion to carry and leave it on the consent agenda.
I'm not sure I caught everything. But what's your recommendation?
I'll come in there.
Okay.
So basically, the item was just registered that I voted no on that item.
Right. So we can still continue to,
right, you can still
vote on that one, Ralph?
Right.
Okay.
I'm a little questionable about Daphne's track days because she reported in her interview that she was very fast. She's not very far from this room and it's taking her quite a while. So maybe she was a long jumper. I don't know.
See, I've never
Better
met
hope she wasn't a boxer.
Yeah, I don't think she ran in heels in high school and college track.
For the record, I'm not a voice coach.
All right, here we go. Daphne's in the room. We're going to get her set up behind a microphone so the rest of you all can.
She is fast.
We probably could have just put this back up on the agenda and had it done faster, but nonetheless.
Yeah, Daphne.
Okay, I'm back.
Daphne, Ralph made a comment while you were in getting here, and he said that he didn't need to pull it. He just wanted to let us know that he wanted to vote no.
That's correct. And that's what I was saying, that it was approved in finance. Unless there's other objections, you can leave it on the consent agenda and move forward.
Okay.
And I think Mr. Fisher's comment was, we're just making sure that if that's the case, it doesn't have to be pulled from the consent item and voted on separately. It can still be voted in that manner. Is that correct, Mr. Fisher? Or have I got that wrong?
No, my only point is the Reverend would like to vote no on that item.
Right.
But he would be voting yes on consent. He'd be voting for that.
Yeah, I think he's just revoicing his objection that he's already raised. So noted.
And my point is, if you want to record vote no, we would need to vote on that item, or that specific item. I don't care when we go. I just want to make sure his objection is recorded.
Sure. It'll be recorded along with the approval of the consent agenda, so it'll be noted.
Yeah, my minutes note and voted no on that particular item.
Is there anybody else in the main office that would like to come to the OPC and explain anything else that they might want to bring up? I think we're good.
All right.
We're good.
exactly how do I have to have this worded, Daphne? I need a motion and a second on the consent agenda.
On the consent agenda, correct.
Okay.
So the same way.
Yeah,
Good.
that's just normal.
Did anybody, I'm sorry, did anybody make that motion?
Longhorn Steve moves that we improve the consent agenda.
Second,
All
DT.
right, is there a second from DT? And the minutes will reflect about Ralph. Okay.
Yes, sir.
All in discussion, all in favor, please say aye.
Aye.
Those opposed say no. Ralph, should you be voting no at this point? I don't know.
No, he's fine. He's fine. We've already.
have it on my minute.
Yeah, we cleared that hurdle.
Pastor Emerson, you have 11, we have 13 people in this room helping and protecting you at all times. I hope you know that.
Well, I just remember sitting in a litigation that had to do, in many respects, with exactly how board minutes were read and interpreted. I never want to go through that again.
Well,
that's
you're good. You won't
okay.
go through here. We all are fine.
Okay, item 12. Daphne, you're up. Report of contracts.
Yeah, thank you, Mr. Chair. We had 40 contracts under 500,000 for the month of March. And the only other thing I wanted to add is this will be the last time that you see this item on the agenda as a standalone raw number. We had mentioned in the past that we would be bringing a law department dashboard on a quarterly basis to the committee, and this report will be included in that. And we'll include information about litigation, collections, and other relevant information for the law department in that report.
Okay, great. The next thing I have on the agenda is to reconvene an executive session. There's one item that I'm aware of, and that's privileges. Do you all want to keep going or take a short break? Roger, keep going. All right. We're going to reconvene in executive.
Yeah, we'll give David time to.
Give us just a second, Dr. Weber. Give us just a second. Thank you, Daphne.
And then connect us.
We'll get things taken.
That will just take seconds.
Yeah, give You're live.
Thank you. It's 14:50 or 10 minutes to 3. I'd like to reconvene in open session for deliberation and or action deemed necessary. And that would be privileges. Cheryl?
I would just like to make a motion to approve the privileging packet as presented in the executive session.
It's Aggie Steve, I'll second.
I didn't catch it.
Aggie Steve said yes. Aggie Steve.
No. How about the other Steve?
The other Steve's
All right.
confused.
He's looking for his football team.
All right. I'm losing control here. What little I ever had. All in favor, please say aye.
Aye.
Those opposed say no. Motion passes, privileges granted. That's all that I have. And if anybody else doesn't have anything, entertain a motion to adjourn.
So moved.
Second.
We're done. Thank you.
Thanks, Chuck.
Everybody.
Good meeting.
Bye-bye.
Appreciate it.
Thank y'all.
Yeah, good meeting.